thing here. Get that going.
Okay.
All right, I'm good.
All right, thanks. And since none of y'all know me, I can just start out by saying I graduated summa cum laude from medical school. I was the smartest person in my medical class. But I am a family doctor. I trained in family medicine back in the 80s. And if you want to do the math, that puts me pretty old. But then I quickly, I worked in the ER for about 4 years and then decided ER was definitely not for me, and went to work with the public health department in South Carolina. And I spent 28 years working for South Carolina, mainly doing STDs, women's health, pap smears, birth control. So basically, I've been talking about STDs for about 30 years now. I promise I'll only tell stories and talk for an hour. So this is one of those topics that I could just talk and talk and talk about because it is something that I've been doing for quite a long time. Hopefully, I'll be able to throw in some stories for you during this next hour or so, and certainly welcome any questions you have. I know STDs. Sometimes I don't know Zoom. So if we have some technical glitches, we'll just abandon ship and just talk at that point. Speaking of the PowerPoint and the lectures, there are some pictures, having done STDs for over 30 years and having some wonderful patients who have wanted to actually help teach. I would tell patients, I do teach medical students and nurse practitioners and PAs and nurses, and they would be very willing to have pictures taken of themselves. So I do have some pictures that illustrate some of the STDs. And I just always thank my patients who were kind enough to be open enough so other folks could learn. So I'm kind of looking around going, is anybody eating lunch? And if you are, hopefully you're not grossed out. I'll try to give you a pictures coming up, heads up. If you're somebody who gets really squeamish with pictures, we'll try to honor that for you too. On the PowerPoint handout that I sent for you to kind of go along with, I've eliminated the pictures. They just don't print out very well, but that's just kind of a disclaimer. A lot of times, like I said, I gear the talk to nurses and pre-professionals, nurse practitioners, PAs. So if any of you are coming into the medical field, we welcome you. It's a great time to be in the medical field. If you're going into psychology and other health-related fields, we certainly are going to need you more than you know in the next coming years as we deal with all the mental health that surrounds what we've been through with this pandemic. And never to underestimate that mental health surrounds just about every medical condition. So STDs are no exception to that. If you have questions, we'll kind of talk about those at the end. Unless it's a burning question, you can put it in the chat. Again, I'm not so technologically savvy that I can talk and monitor the chat. But Denise is going to monitor that and jump in if need be. Having given talks a lot, I like to research things about talks. And what people tell you that is, if you're lecturing, people are only going to learn 3 things. And it's always interesting at the end of the talk, I always like to say, what 3 new things did you learn? Now, that doesn't mean if you learn the 3 things in the first 5 minutes that you can just click off. Okay, I'm going to keep talking. And the other nice thing about Zoom is once I go to my screen, I really can't see you. So if you need to get up and walk around, take a nap, whatever, that's fine. Research says that 30% of you, 1/3 of you, did not sleep very well last night, and you're kind of sleep deprived. And what folks will tell you is that even when I was in person, it wouldn't matter to me if you got sleepy. So don't try to do this head bob thing, just kind of put your head down. I'll keep talking no matter whether you're asleep or not. And we're recording this, so you'll have a chance to go back and get the information. So without further ado, I'm going to try to share my screen and get the PowerPoint up. And I am in actually my exam room. So if someone knocks on the door to ask me a question, I'll just try to keep going and get them to do something else. So let's see if there we go. All right. So again, started my career learning about sexually transmitted infections when I was in medical school in the 80s. And there's been some changes in STDs. There have been a lot of things that definitely have not changed with STDs. One of the things that has changed, and I'm catching myself doing it, we used to call them STDs, D as in dog, sexually transmitted disease. We've changed that to call it sexually transmitted infections. I don't know why we changed the name, but we did. So STIs, STDs are the same thing. If you really want to go back, we used to call them venereal diseases or VD. So that's a very old term. It served us quite well though, because we used to celebrate Valentine's Day in a way that no one else on the planet did. We would want everybody to get tested for sexually transmitted infections on Valentine's Day. So if you ever hear people call it VD, that's again the same thing. So what do we know about STDs and how prevalent they are? This is an older slide that shows you that the pregnancy rate, one of the areas that I used to work in was teen pregnancy and the prevention of teen pregnancy. And you can see from the slide that the pregnancy rate since about the 1990s has steadily gone down for teenagers. The birth rate has gone down and the abortion rate has gone down. So in some ways, we're doing a lot of good things around sex as far as preventing pregnancy. Unfortunately, we are not doing as well with STDs. STDs are actually going up, and the latest data from the CDC showed that STDs have really increased in the last 2 years. So if pregnancy is going down and STDs are going up, well, we know people are still having sex, but obviously they're protecting against pregnancy, but not so much against STDs. One of the things that we think may be involved with this is that people are using more effective methods of birth control. So the IUD, the implant in somebody's arm, are very, very effective in preventing pregnancy. So if the only thing you're worried about is, gosh, I hope I'm not going to get pregnant if I have sex, you're kind of covered. But it leaves wide open STDs. That's why I still have all the condoms on my office table that I tried to encourage and give out. But we know that the prevalence estimates in the 15 to 24-year-old age group just keep going up and up and up, even though we've got all these great birth control. This is an old study, said that women 15 to 19 had the second highest rate of gonorrhea. We know that chlamydia is also increasing. What is a little bit scary is diseases like syphilis are increasing. So we really don't have a good handle on preventing STDs. So again, I answered my own question on the next slide. So why a decrease in pregnancy rate and not a decrease in STDs? So it may be a lack of knowledge too. We may be talking more about preventing teen pregnancy, than we're talking about preventing STDs. So this was a study that asked teenagers about their knowledge of STDs. Most of them could identify HIV as an STD, which with all the information about HIV, you would hope that everyone would know that HIV is a sexually transmitted disease. Only 2% could name all 8 major STDs. Only 9% could name the 4, what we call curable STDs. Only 3% could name the 4. They called it incurable. I call it treatable and curable. So everything, the nice thing about STDs now is everything is treatable. So since you're in this class, let's see how well you can do. So naming all 8 of the curable versus treatable STDs, and I'll give you a hint, there's 4 in each column. So if you can kind of think through, see how many you can get. I'll take a sip of tea and let you think on that.
I'll start us off. Syphilis.
All right. Do I have any other brave people that want to throw out a guess in there? That's okay. This is not in your handout because I didn't want you to cheat and look at the next slide. All right, so our curable STDs, Professor is right, syphilis is on the list. Ding, 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 ding. Probably most of you had in your mind gonorrhea and chlamydia are curable. So we have antibiotics that cure gonorrhea and chlamydia. Trichomonas may not even be on your radar. You may have heard of it, but that's another one of the STDs. Treatable, which the study called incurable, but treatable STDs include HIV, herpes, HPV, and hepatitis B. Now, a lot of you don't even think about hepatitis B being a sexually transmitted disease because you were vaccinated against it. If you grew up in the state of North Carolina or South Carolina and attended public school, you had to have a hepatitis B vaccine. Interestingly enough, that vaccine does help prevent hepatitis B. And since it is a sexually transmitted infection, a lot of times, you might wonder, why did I get it as a baby? And we put it in the vaccinations with babies because we've not had a really good success of putting vaccinations in the 10, 11, and 12-year-olds. So if we can get it in with the childhood vaccines and get everybody vaccinated, but we have definitely decreased the incidence of Hep B here in the United States. So one more question. You got a 1 out of 8 chance. Which one would you say is the most prevalent? And if you guess chlamydia, you are correct. Now, a lot of people would go, well, wait a minute, what about HPV? So when we're talking about HPV, we're usually talking about genital warts, but you're right. If you said HPV, I'll give you the answer too can be that, because that is a very, very prevalent type of sexually transmitted infection. Most people who are exposed to HPV through sex actually clear the virus themselves without any treatment. And we'll talk about that when we get to the HPV. So we're going to talk about we're not going to talk about Hep B because that's one of those ones that you're vaccinated against. You'll probably never really come up against, but we'll talk about the other 7 as far as STDs. All right. So this study looked at condom use. And in a study in Indiana, the respondents were parents, and 77% of parents thought that correct condom use should be taught in the public schools, but fewer than half thought we should actually give out condoms without parental consent in the school. Now think back to when you learned about sex in school and who taught your sex ed class. And it might have been the PE teacher, or you might not have even had a sex ed class. We all agree that condoms and education help decrease sexually transmitted infections. But it's very interesting in our country how much resistance there is to actually providing condoms at school, or birth control at school, or school-based clinics. The thinking is, gosh, if that's available, it's going to make folks have sex. And study after study after study has shown that that's just not true, that people can have education, they can be provided with condoms, and it does not impact whether or not they plan to have sexual activity.
Can Can I add something here about rurality?
Yes.
We've got several faculty and several of our graduate students out in the local high schools. And one of the things that we hear from students that in these rural areas, oftentimes there's only one drugstore and anybody who works the counter knows you by name. And that's a barrier for a lot of students, particularly where you get, kind of heavy religiosity. And they're not, buying condoms is not being safe. Buying condoms is like, ooh, they're having sex.
Right.
And so
Right.
we've got other layers of barriers in these.
Absolutely. Absolutely. The same with birth control. If you're going to get birth control from somebody who also takes care of your mother and your grandmother and your aunt, and you're kind of worried that they may say something which they shouldn't, and you don't have a federally funded health clinic or a Planned Parenthood or a health department that you feel comfortable going to, where are you going to get birth control except condoms? And then if you do have to go in the drugstore, I don't know if any of you've ever bought condoms in the grocery store. I would say everybody go out today and buy condoms, okay? Just to see how it feels when you're checking out. And sometimes I do this just kind of for fun. I'll have my condoms and my milk and my bread. And of course, being older, it's kind of fun because the woman looks up at me and I just kind of smile, But for teenagers, for young adults, it's very uncomfortable. Again, that's why I have the condoms in my office. So if you come for a cold or whatever, there's condoms that says, please take one. So a lot of different people don't even know what gonorrhea is. The doctor said he had several cases of gonorrhea, and the answer is, well, don't you buy any. We've got several cases of Merlot. So it's not a wine. Let's talk about gonorrhea. Older data, but still very relevant because you can see that the age group that's most affected by gonorrhea in this country is the 15 to 24-year-old age group. And this will be a broken record with all the STDs. Notice that women are equally affected as men. That's one of the myths that I want to just kind of blow up. And this may be one of the things that you write down is that men who have sex with women, women who have sex with men, men who have sex with men, and women who have sex with women can all get STDs. There is no demographic where STDs aren't present. So gonorrhea is caused by the bacterium called Neisseria gonorrhea. It's a bacteria that grows and multiplies in warm, moist areas of the reproductive tract. So we think of it being in the cervix, we think of it being in the uterus, we think of it being in the fallopian tubes, and also in the urethra, or that's the tube that is in the male penis. Also the tube that's in the female, but both sexes have a urethra. That's where we urinate, okay? So it also grows in other areas outside the reproductive tract, notably in the mouth, in the throat, in the eyes, and in the anus. That's one of the reasons when we're talking about STDs that a sexual history is so important. Because if you make the assumption that your patient is having heterosexual sex, and you make the assumption that the sex is penis in the vagina, then you may actually miss where the STD is. So it's very important. And if you've ever come to see me, one of the first questions I ask my patients is, are you sexually active? And is it with men, women, or both? And if it is, then I ask, do you have vaginal, oral, or rectal sex? And then go on to say, is it insertive anal, insertive oral, receptive oral, or receptive anal? So, I mean, there's just a lot of ways that people can have sex. And unless we know how people are having sex, we may not know exactly where to look for the STD. The other thing that we know with gonorrhea and how is it spread, coming in contact with a penis, a vagina, a mouth, or an anus of an infected person can transmit gonorrhea. Ejaculation doesn't have to occur for transmission of gonorrhea to occur. And we also know that moms can spread it to their babies during delivery in the vagina. So that's one of the things we do with all our pregnant patients is we always culture for gonorrhea and chlamydia during the pregnancy so that transmission will not happen. So what are some of the signs and symptoms? How do you know if you've got gonorrhea? The problem is, look at that first symptom for men. No symptoms. So how the heck are you going to know you have something if you don't even have a symptom of it? So that's one of the reasons that STDs can be transmitted is because people aren't being bad or mean. They just may not know they have it. That's why you kind of have to assume people have STDs until they've been tested and make sure they don't have STDs. And that's why condom use is so important. But if men are going to have symptoms, a lot of times they'll have a burning sensation when they urinate. They may have a white, yellow, or green discharge from their penis, or they may have swollen or painful testicles. This can occur 2 to 5 days after a contact with an infected person, but as long as 30 days afterwards. So there's no like one time frame for transmitting the infection. This is the picture before the picture. So I'm warning you that some other pictures are coming up. I remember a patient that I had back, and he came into Charleston, and he was just kind of screaming, like, "Cut it off, doc, cut it off, cut it off." And I was like, "What? No, I'm not going to cut it off." The burning sensation was so much for him. He literally had a wad of toilet paper wrapped around the tip of his penis because he had so much discharge. So there can be a lot of burning and a lot of pain. So if you're in the medical field and you see somebody who's having a lot of burning and a lot of pain, one of the things you're going to think is gonorrhea. This is the actual patient who had gonorrhea. So it's a discharge from the tip of the penis. In the cervix, you can see this is a cervix here. So I'm looking through my speculum, and this is the discharge that's coming out of the cervix. Again, women can have minimal or no symptoms or very non-specific symptoms like a bladder infection or a vaginal infection. So a lot of times when people come in here with what they think is a bladder infection, I'm also going to check for gonorrhea and chlamydia just to make sure it's not one of those things. So what happens if we don't treat gonorrhea correctly? Well, we can get pelvic inflammatory disease, which is a scarring of the fallopian tubes that can lead to increase in risk of a tubal pregnancy or ectopic pregnancy or even infertility, and also pain. If your uterus gets infected from gonorrhea, there's going to be a good bit of pain in your uterus. Guys can get epididymitis. So the epididymis is an organ that sits on top of the testicles in the scrotum. And the other thing with gonorrhea is it can spread to the blood or can go to your joints. So there definitely are complications with gonorrhea. So more pictures for those of you who are squeamish. This is gonorrhea in the eye. This is a patient who came in who had disseminated gonorrhea. So these little bumps here turned out to be from his spread through the blood. This is a patient that I had who had gonorrhea here on her fingers. So again, I mean, you're thinking, this isn't what I usually think gonorrhea looks like, but it can definitely spread. And then, of course, complications to the infants born to infected moms. There can be blindness. Most of you don't remember when you were born, but your mom will probably tell you they put goop in your eye. And the reason we put goop in the eye is to make sure that we're treating we do it to every newborn in case the baby has been exposed to gonorrhea. So that's why we put that stuff in the eye still. And there can be blood infections, there can be joint infections, just like we talked about. So how do we diagnose gonorrhea? Well, used to be that I would have to take a swab, and I would have to either swab in the penis to get that discharge, or I'd have to swab in the cervix to get that discharge. Then a test came along where we could just use urine. So remember, in males, the urethra is where the gonorrhea is, and it's also where they urinate. So getting a urine sample, we get gonorrhea. So NAAT, N-A-A-T, stands for nucleic acid amplification test. So basically we're getting the DNA of the gonorrhea or the chlamydia. So instead of having to do swabs now, we can just get urine samples, which has greatly helped in people coming in to get tested. Because if you're 15 or 16 and you're worried about having gonorrhea, the last thing you want to do is go get a pelvic exam to be tested. But if I tell you, gosh, all you got to do is pee in a cup, then folks will do that. Some people don't know this, but at App State, you get one free gonorrhea and chlamydia test a year. So if you haven't gotten your free GC and chlamydia test, I say come on in and pee in a cup so we can diagnose it. We used to do gram stains. We don't do those anymore. And we'll talk a little bit about gram-negative intracellular diplococci, which is what Neisseria is. So this is the old way we used to do it. This is a white blood cell. White blood cells fight infection. You notice this one looks a little bit different. It's got a lot of spots in it. That's actually the gonorrhea bacteria, and it stains gram-negative. So in the old days, we could take the discharge, we could do a gram stain, and I can tell you this is gonorrhea because it's got gram-negative intracellular, it's inside the cell, diplococci. Now I just make you pee in a cup. So a little bit of history. When did we have a cure for gonorrhea? Not until the 1940s. Not until World War II. So here it is, you know, buy your bonds, you know, and penicillin cures gonorrhea in 4 hours. This is an old mailbox, okay? So this is how folks used to get public health messages out. The problem with gonorrhea is it's a smart little bacteria and it started to get resistance to a lot of medications. So we used these medications first, then we went on to these medications, then we went on to this medication, and the gonorrhea got resistant to it. So much so that now we're using a shot, okay, to kill gonorrhea. But the CDC has listed this as an urgent threat, that drug-resistant gonorrhea is a real threat. Now, before COVID, you know, we would talk about things that the CDC thought were threats. Obviously, COVID took over and became the threat. But this is how many, you know, 820,000 gonorrhea infections in a year, all right? And almost 250,000 drug-resistant gonorrhea infections. So if we lose our ability to be able to treat gonorrhea with antibiotics, then we're going to have those complications. So this is definitely a threat in public health. And there's the 2013 emerging antibiotic resistant threats. So if you come to the doctor and you want antibiotics for your virus and we don't give them to you, this is why, because we don't want any organism to get resistant to the antibiotics we have. So that's the old way we used to treat gonorrhea. And as of December 18th, 2020, hot off the presses, the MMWR came out with the new dose. You give 500 milligrams of Rocephin or ceftriaxone in a shot. And if you haven't excluded chlamydia, you give doxycycline. Now, a lot of you who are going into the professional med school, nursing school, you may see people treating it like this, because like how many people actually read the MMWR on December 18th, 2020? We had other things going on like COVID and Christmas, and only nerds like me read this. So, all right, so but that is the current treatment, and it has been evolving because of antibiotic resistance. So a lot of clinics will go ahead and treat people for gonorrhea before the test comes back. Here at Student Health, we know we can find people, so we wait and see if somebody needs the shot and the medicine. So that's gonorrhea. Second one is chlamydia. Again, caused by a bacterium and spread through vaginal, oral, and anal sex. And again, can be passed from mother to baby during vaginal delivery. So just like gonorrhea, kind of the same. And that's why a lot of times I talk about gonorrhea and chlamydia kind of in one breath. No surprise here. Look at the rates, 15 to 24-year-olds. And look at this side, women. All right. Why do we have so many more infections in women than men? And really, we don't. We're testing women more. So the recommendations are that all sexually active women 25 and under be tested for chlamydia once a year. That's why when you go see your gynecologist or you go see your family doctor and you're 25 and under and you're sexually active, you're going to be tested for chlamydia. The same recommendation is not made for men. The reason being the consequences of undiagnosed chlamydia in women are so much worse. And so that's why the recommendation from the CDC came out for women, but not for men. Personally, I think men and women, sexually active men and women 25 and under should be tested once a year for chlamydia. So again, what are the some of the symptoms of chlamydia? You can have an abnormal vaginal discharge. You can have burning when you urinate, abdominal pain, low back pain, nausea, fever, pain with intercourse, or bleeding between periods. So bleeding when you're not supposed to be bleeding. That's kind of the one that I highlight for all the pre-professionals, is that if you've got somebody who's having irregular menstrual bleeding, let's test and make sure that it's not gonorrhea or chlamydia. Chlamydia on the cervix, sorry, forgot to warn you. Pictures coming up. You can see this is the cervix and the discharge coming from the os of the cervix. Men can have a penile discharge. They can have burning with urination. They can have burning or itching around the opening of the penis. If they have chlamydia in the rectum, they can have rectal pain, discharge, or bleeding. And also chlamydia for folks who are having oral sex can present as a sore throat. So now hopefully all of you, when you get sore throat, won't immediately think chlamydia, but it is on the differential, especially if you're having unprotected oral sex. The treatment hasn't changed. We use azithromycin, usually 4 pills. You take them all at once and it treats chlamydia. If we're not using azithromycin, we use doxycycline and we use that twice a day for 7 days. When you talk about STDs for 35 years and you travel around the country, you find a lot of fun signs. Can you even imagine if we had a sign like this? Chlamydia, capital of Canada, woohoo, get tested. It's easy as 1-2P. We in the South do not talk about sex or sexually transmitted diseases quite as openly as they do in Canada, I suppose. Some more, I've got chlamydia, that's nice, dear, put it in the greenhouse. I can remember when I was talking, I was asked to talk to the medical auxiliary. At that point, it was the wives of the male doctors. And one woman indeed did say, "Oh, chlamydia, that sounds like a flower." And I said, "No, ma'am, that's clematis is the flower. Chlamydia is an STD." So a lot of misinformation. How do we treat it? Azithromycin again. And if they're not pregnant, we can use doxycycline. Again, these slides you don't have to worry about because you're not treating the STDs. So kind of touched on the top 2, gonorrhea and chlamydia. Moving on to HPV, or human papillomavirus. Over 100 types have been identified. Actually, over 200 types have been identified. So there's not just 1 or 2 HPV types, there's hundreds. But certain ones that we focus on are number 16 and 18 because they cause cervical cancer. And then types 6 and 11 cause genital warts. And we're really going to be talking about genital warts and vaccination. Vaccination could literally turn this around so that everybody could be protected against human papillomavirus. We didn't do a very good job with this rollout of the immunization. You should have gotten it when you were 10, 11, or 12. It was not a required vaccine, so a lot of people didn't get it. And people thought, well, gosh, if I give my sweet child a vaccination, they might have sex because it prevents things that are sexually transmitted. So If you haven't gotten the HPV vaccine, it is very effective. And I would say, ask your parents if you've had it. And if you haven't, think about getting it. The reason is HPV causes more cancers and diseases in men and women globally. Penile cancer, vaginal cancer, anal cancer, head and neck cancer, cervical cancer, and then look at all these with genital warts. So we should have marketed it as a cancer preventing vaccine when we first rolled it out, and not as a vaccine that protects something that you get exposed to when you have sex, because that didn't work. More and more people are getting vaccinated for HPV, and I think that's great. And a lot of commercials, one less was a commercial that came, so you could be one less person affected by cervical cancer. And then the age groups have expanded. So it used to be up until age 26. Now it's up until the 40s. So folks can be vaccinated. You would like to vaccinate someone before they ever have sex, which is why we put it in the 10-year-old, 11-year-old, and 12-year-old age group. But even if you've had sex, you can still be vaccinated against HPV. So talking about HPV type 6 and 11, they cause genital warts, or Condyloma Accuminata is the old terminology for them. Estimated that there are about 1 million new cases in the US each year. Interestingly enough, in Australia, where they mandated the vaccine and provided it through the government, teenagers rarely have genital warts. So it definitely, there's some great data out there that the vaccine does prevent genital warts. So these are genital warts. Looks like little pieces of cauliflower is what I tell people, and this is quite a lot of genital warts. Sometimes we'll put vinegar and it makes them turn white. But again, this is one of my patients who had extensive genital warts. And how do we treat it? The treatment now is a drug called imiquimod or Aldera that can be applied to the genital wart to kill the virus. Bedophilox is something we used to have in our offices. You can do cryotherapy, but usually cryotherapy is a little uncomfortable in the vaginal area or the penile area. If they're really bad, you can have surgical removal of the genital warts. And there's the treatment again. So again, about vaccination, when it first came out, it was it had 4 different types of the HPV virus: number 16, number 18, number 6, and number 11, because we wanted to protect against genital warts and cervical cancer. Now there are 9 different types of HPV, 9 types of the virus in the vaccine. Some of the 30s that also cause cervical cancer. Used to be a 3-dose series. Now, if you get your first dose before age 15, you only need 2 doses. And I encourage everyone to make sure that you've been vaccinated, because it's the anti-cancer vaccine. So protect yourself from all the different kinds of cancer through vaccination. Moving on to something that sometimes gets confused with HPV is HSV, or herpes simplex virus. So you can see how there's only a 1-letter change in HPV and HSV. So herpes is caused by the herpes virus type 1 or type 2. So 30 years ago, we used to say herpes type 1 was above the waist, herpes type 2 was below the waist. Now we say you can have oral herpes, also known as cold sores, or genital herpes, and it can be either type. That's one of the messages I think that needs to get out to sexually active people more, is you can have a cold sore. You can have the herpes virus on your mouth. That obviously wasn't sexually transmitted. You might have gotten it when you were a child. But if you are engaging in oral sex, you can pass the herpes virus on through sexual activity, even though it's not what's considered penile vaginal sex. Most people who are infected don't know they're infected. So at least 45 million people over the age of 12 have genital HSV. So about 88 million people in this country have the herpes virus. What are the signs and symptoms? Usually blisters on the genital or rectum. The first outbreak is usually more severe. You're kind of sick. You feel like you've got a virus, and then you have pain in the genital area. The problem with herpes and what makes it such a tricky little virus is you can shed the virus even when you don't have an outbreak. So that's why we recommend condom use. There is medication to treat the herpes virus. We have acyclovir and Valtrex that can suppress the virus. It doesn't cure the virus. It doesn't take it all the way away, but it's definitely a treatment for herpes. And we do know that if a mother delivers a baby vaginally and she has herpes, it can cause severe disease in a newborn. So this is kind of a little tough to see, but these are the little blisters right in here that go along with herpes. For those of you who are very observant, these are my patient's hands. These are not my hands because they don't have gloves on them. But when we diagnose herpes, we take a Q-tip and culture this area to actually grow the virus and to know what type it is. This is a very painful condition. There are blood tests for herpes. I usually don't tell people to do screening for herpes with the blood test, simply because what are you going to do with the information? So if someone has an outbreak, that's when we culture and that's when we test for it. And then no change in the recommended treatment for years. Moving on to Trichomonas. This may be one that you're not quite as familiar with. If I could wiggle my screen somehow, Trichomonas is swimming under the microscope here, and that's how we diagnose it. So this is a little trichomonad. This is another one. They have a little flagella on them that makes them swim around under the microscope. So the way we diagnose Trichomonas is to get discharge from someone who's infected and then look at it under the microscope. There's another little Trichomonas. So again, the trichomonad with his or her little tail swimming around. So usually someone who has Trichomonas has a thick, kind of frothy vaginal discharge, or in men, they would have a penile discharge. Trichomonas is very easy to treat. You take a medicine called Flagyl or metronidazole, and you take 2 grams of it, and you take it once, and that kills the trichomonad. The kicker with this medication is you want to make sure that you're not taking it and drinking any alcohol, because it will make you throw up horribly. So this is one medication, one antibiotic that we always tell people don't drink alcohol. Sometimes the medicine can cause a kind of metallic taste in people's mouths. Some of my patients told me that if you took it with peanut butter or potato chips, it cut that metallic taste. It's the only time I recommend potato chips to my patients is when I'm treating them with metronidazole or Flagyl. So moving on, we're getting through them all. HIV. Back in the 80s, when I was diagnosing folks with HIV, and what you've got to realize is that actually in my professional lifetime, we've gone from HIV being a virus that, number one, we couldn't even test for. We didn't know what was causing these folks to be so sick, to a virus that now we can have medication for, that we can actually suppress the virus so that people live normal, healthy lives. And for those of us in the HIV world, that is absolutely huge. Everybody loves Anthony Fauci because of his COVID things, but Dr. Fauci has been the rock star in the STD world because of all his work with HIV. And really before COVID, this was what he was known for, was all his work there. And so HIV is a virus, and it is transmitted sexually. And what the symptoms folks will get are kind of like a viral infection. And so that's why blood testing is so important, because most people are not going to come to the doctor if they have a mild viral infection. The demographic that is most susceptible to HIV is men who have sex with men, but it is in the heterosexual population. So don't think just because you're not in one demographic that you're immune from HIV. How we kind of look at it from a national strategy is we want to identify undiagnosed infections. We want everybody to be tested for HIV, simply because now it is so treatable. And the earlier we find it, the easier it is to treat, and the longer, healthier lives people will live. This is the diagram that you don't have to know unless you're doing HIV testing, but basically we've gone through 4 generations of testing. We're on the 4th generation of test. And the good news there is we've shortened this window of when you might know you are infected with HIV. So here you get infected with HIV, and we can start picking up evidence of HIV at 10 days. So in previous times, you would have to be tested in 2 weeks, and then 3 months, and then 6 months to make sure we didn't miss it. Now we can test at the 10-day mark and have an idea of whether or not somebody has HIV. The other thing about HIV is that now we're using a medication that we use to treat HIV to hopefully prevent people from getting HIV. And it's called PrEP. So pre-exposure prophylaxis, or PrEP. If I have a patient who is who's a male who's sexually active with another male, and that other male happens to have HIV, the unaffected partner can take PrEP and have a decreased chance of getting HIV. Now, one of the things that has happened with PrEP is that unfortunately, or fortunately, we've had less people get HIV, but then people think, oh gosh, well now I don't have to use a condom. And guess which STDs are going up? Gonorrhea, chlamydia, syphilis. So sometimes when we have a treatment for one condition, we have to also remember you still have to use condoms. So, and I think last but not least is syphilis. My poor 88-year-old dad, I would be on the phone consulting about syphilis, and he'd go, syphilis? That's still around? Like, yeah, Dad, it is. Caused by a spirochete. And this is the little spirochete here. Looks like a little corkscrew. And syphilis can pass from person to person through direct contact with a syphilitic sore on the genitalia, the vagina, the anus, the rectum, the lips, or the mouth. And syphilis is in 3 stages, and that's what makes it kind of a tricky infection. Syphilis is really prominent in the South. This is an old slide. For 1 year, North Carolina was actually the leader in syphilis in heterosexual population, not in the not in the men who have sex with men population. So again, if you think just because you're having heterosexual sex that you're safe, I tell people you need to get tested. So primary syphilis usually is a single sore, and the problem is it's painless. So folks may not even know they have it because they don't have any pain, versus herpes, which is a painful sore. It'll last 3 to 6 weeks, and then it heals with or without treatment. So if you feel like you've got a sore and you don't want to go to the doctor, and then 3 weeks later it goes away and you've not had any treatment. This is what the primary sore looks like in a drawing. And if you scraped material from that and looked under the microscope, you'd see the spirochetes. This is an actual patient who had a painless sore here. She didn't even know she had it. So that was just a lucky call that she came in that day. This is a gentleman who had a rather large chancre. Again, This looks like it would be very painful, but it was painless. But when we cultured it, it showed syphilis. So those things, believe it or not, are going to go away by themselves, whether or not I treat them or not. But if we don't treat, then it goes on to secondary syphilis, which can cause a skin rash, lesions in the mouth. You can have a whole bunch of symptoms: sore throat, fever, patchy hair loss, muscle aches, fatigue. And then look at this, it resolves again with or without treatment. So this is the classic rash of syphilis on the palms and soles. We actually had an outbreak of syphilis here in Watauga County. A patient came in with this classic rash. He was tested for COVID. I looked at the rash and said, well, that's secondary syphilis, just because I've seen secondary syphilis a lot. Sure enough, tested him, and he had seen several other clinicians who had not diagnosed this, and it would have resolved with or without treatment. We do contact tracing with all STDs, and we found 4 or 5 other partners who also were infected with syphilis. So it is in North Carolina. It is in Watauga County. This is a woman with secondary syphilis. Again, this looks like it wouldn't heal, but this would heal by itself with or without treatment. But this is secondary syphilis in one of my female patients. It's kind of hard. I'm taking the picture from up above, and so he's pulling his lower lip down. And so these are syphilitic ulcers in the mouth. So let's say we didn't treat secondary syphilis, then it goes on to tertiary syphilis. And this is where it affects the brain, the nerves, the eyes, the blood vessels, the liver, and the joints. You can't transmit syphilis sexually at this stage. It's kind of, if you can imagine, gone into the body. But it can lead to paralysis, numbness, dementia. So if your grandmother or great-grandmother ever has a dementia workup, one of the things they're going to test for is syphilis, to just make sure that there's no exposure. Again, goes to the internal organs. Congenitally, it can be passed on to babies. And this is why we test all moms for syphilis when they're pregnant, because we want to catch it before it gets to the babe. How do we diagnose it? Well, we used to look at things under the microscope from the lesion or the chancre. Now we do a blood test. So it's just a simple blood test. That's what it looks like under the microscope. But this is what we usually draw. If it's positive, we report it in the titer 1 to 2, 1 to 4, 1 to 8, etc. There can be false positives, like with any other blood test. Some of the things that cause false positives: IV drug use, Lyme disease, malaria, sometimes even pregnancy or older age can cause a false positive syphilis. That's why we have this second test that we run if the first test is positive, to make sure that we're dealing with somebody with syphilis. How do we treat syphilis? Syphilis hasn't changed. We still treat syphilis with penicillin. And for those of you who've been binge watching Grey's Anatomy during the COVID lockdown, I don't know if you realized that episode, but that's what they were treating him for, was he was positive for syphilis. So good old penicillin. So that's how we treat it. Syphilis is worldwide. This is something that when I was in traveling, here was Dr. Melangi. He does international shoe repair and syphilis. So everybody needs to know how to treat syphilis. I told you that I worked for the public health department in South Carolina prior to coming to Appalachian State University. This is the building where we did all our STD testing, all our clinics. And I don't know if you can see what this says, so I kind of zoomed in on it. Yes, we worked at the asylum. It used to be the asylum back before we took it over for STDs. And there were some days that we got out of there and we thought, indeed, we have been in the asylum all day. Always remember, you need to have safe sex, wear a condom. And I thank you for your attention and would be happy to answer any questions you might have.
For you psych majors out there, what is it's known as one of the most unethical experiments that medicine has ever done. And it's part of the reason why we have institutional review boards, and it involved syphilis. What's that experiment known as?
The Tuskegee, I'm probably saying it wrong, but.
Oh, you're saying it right.
Okay.
Yeah, Tuskegee. So what they did in Tuskegee, and it's also a reason that a lot of times some of my African-American patients were very, very hesitant when I was talking about diagnosing syphilis. Because what they did in Tuskegee is they were studying the natural history of syphilis. The problem is they continued to study the natural history just to see, before the 1940s, we didn't have penicillin. So we didn't have treatment. People used arsenic, they used lead, they used all kinds of things that did not treat syphilis. And so this group of people in Tuskegee, Alabama, were being studied about the natural history of syphilis, which is why we know that if you don't treat it in the primary stage, it goes to the secondary stage. If you don't treat it in the secondary stage, it goes to the tertiary stage. The problem was, even after we had adequate treatment for syphilis, it was not given to these patients. So we continued to let people suffer with a condition that we could have treated. And I think the last, and it was a wife of one of the patients who we initially diagnosed with syphilis, just recently died in her 90s. So it is not something that's way, way, way back in history. It is something, again, that grandparents may have known about and told their children who have told their children. And so that's why there may be a reluctance. And we in the public health department understand that people may not want to come to the public health department because it was run through the public health system in Tuskegee, Alabama. And it's a shameful, horrible black mark on public health. But yeah, so as psych majors, as people who, when we try to get to the reason that people don't come to get treatment, a lot of time it's fear or lack of trust. So if you think that I come from a line of professionals who actually, obviously I had nothing to do with Tuskegee, but if you don't trust medical professionals, you're not going to come get treated. The other reason is fear. Back in the 80s, when we were treating folks for HIV, we would diagnose it and there was really nothing we could do because people died, so we could just cry with them. We used to give them handfuls of pills that sometimes worked and sometimes didn't. So if that's kind of what you have in your mind, now it's hard to kind of wrap your head around, gosh, I can come get an HIV test. And if I have HIV, I can take a pill every day. I can totally suppress the virus so that the virus is not even detectable. We don't call it curable because if you get off that medication, then the virus rebounds, but it's definitely treatable. People can live into their 60s, 70s, 80s, just as if they didn't have HIV. But a lot of people are scared to get tested for HIV because they don't want to know, or they think, I couldn't possibly have it. Anybody who's had sex could have been exposed to the HPV virus and the HIV virus. So that's why I tell folks, at least once in your early sexual career, get tested for HIV. If you're in a higher risk group, get tested more often. And we have different testing recommendations for different groups. So yeah, don't be afraid of being tested for STDs because they are treatable and they are curable and they are preventable. with condoms or abstinence. Yeah. When you do STD talks, you assume everyone's having the S, right? So that's kind of the assumption from clinical standpoint.
Can you speak a little bit to how women who have sex with other women can protect themselves?
Great question. Women who have sex with women, and I'm looking in the chat. Yes, the correct term is men who have sex with men and women who have sex with women. Sex toys, fingers, oral are probably the three ways that women who have sex with women can be infected. Just because there's no sperm in the picture and so there's no risk of pregnancy doesn't mean that there's not risk of spread of STIs. And to your point in the chat, I've just had a lifetime of working with some such wonderful people. And you're right, a lot of people who have sex with men who have sex with men, absolutely do not identify as gay or homosexual. Those words just aren't used. So if you use those words and you ask somebody, are you gay or are you homosexual? They'll tell you no, when indeed they're somebody who has sex with men. They also may have sex with women. And that's why I think it's real important to kind of know exactly what the sexual history is.
I know that that is particularly the case in the South, that a lot of men having sex with other men don't identify as gay. Is that universal, or is that a little bit of a kind of a Southern?
It's definitely Southern. I have had Northern colleagues who will tell me the same thing. So I would say it's probably more universal.
All right, what questions do you all have? I'm curious, has there been enough time to track, is STI transmission down at all if people have been isolating?
Nope.
And I know I have some clients who have been isolating, but then they're still having sex with new partners.
Yes, yeah. So we kind of, not that we laugh about STDs, but yeah, STDs across the nation have not gone down, even in the time of COVID. So I don't know if people are having sex with their mask on, or exactly how this is happening, or if, that's their pod. And so, but yes, that's a great question. And no, it's not. In fact, somebody cut out a little cartoon for me and gave it to me. And it has this kind of cartoon figure that's a condom and a cartoon figure that's a mask. And the caption is, "So they won't wear you either." The condom is talking to the mask. So I'll have to put that in the next talk. Yeah.
It's another good reason to stay away from the unmasked.
Yeah. The unprotected. But yeah, no, we have not seen a decrease. Now, it'll be interesting, in the next year or so to track that data, because that's the problem with STD data. A lot of times it lags because what we do here as a doctor's office is we report STDs to the public health department. Our local public health department reports it to the state health department. The state health department reports it to the CDC. So all that reporting, and not by name, just by number. So, we may say here at Student Health, we had 10 cases of gonorrhea and chlamydia this week. And that gets reported on up the line. Chlamydia and herpes are probably the two STDs that we see most often here at Student Health.
What's the average time it takes for herpes to show up after the initial contact?
Great question. And it is so variable because the herpes virus, you can get exposed to the herpes virus, you cannot have an outbreak, and the herpes virus kind of goes into the nerve the nerve cell of the area, whether it's in the mouth or the genitals. Then under stress, under any other condition, the herpes virus can come back out, and that can be your first outbreak. So if somebody tells me they've had sex with 6 people and they're coming in with a herpes outbreak, all of us would like to point to the most recent partner, right? It's got to be him, right? But unfortunately, we can't say that because it could have been any of the 6 sexual partners that could have transmitted the herpes. Now, usually it's within 5 days to 2 weeks if you're going to have an outbreak from that encounter. But I cannot say that that outbreak is from that encounter. It could have been from a previous encounter that now is getting reactivated. A lot of people say, well, how likely is it that I'm going to transmit herpes? Well, we're not going to do those studies. I'm not going to take 100 people and say, okay, you 50 people who have herpes have sex with people who don't have herpes, and you 50 people who don't have herpes have sex, and let's see who gets herpes. And so we don't know exactly, like, is it 10%? Is it 50%? We know it's not 100% because not everybody who has sex with somebody who has herpes gets herpes. But we just don't know because we'll never have that data. So great question though.
Thank you.
Can herpes be transmitted through like just water and drinks and drink sharing?
So the herpes virus can be, so if you had a cold sore, an oral lesion, and you drank, and the herpes virus was on that inanimate object, and someone came behind you and drank behind it, and they had a break in their skin, because that's the key that herpes has to, it will not go through intact skin, but it'll go through a break in the skin. So yes, a much rarer way, because the herpes virus doesn't live long on the inanimate surface, but possibly, yes. You can also auto-inoculate yourself. So let's say you had a cold sore, you wiped your mouth, and then you touched your genital area, and you had just shaved, and you had some breaks in your skin. You can auto-inoculate yourself with herpes. So again, that's why it's such a tricky little virus, because a lot of people will have cold sores, and they don't think of that as being sexual because they didn't get it obviously by having sex. Their mom could have kissed them or whatever when they were little, but it is possible to transmit oral herpes to the genitals if you're having oral sex.
I have a follow-up to that. Since my mother taught me to hover over public bathroom seats all my life.
How likely are you going to get an STD from a bathroom seat?
Yeah,
Not likely, because the skin's not broken. So, and again, the inanimate object of, if somebody came before you and had herpes on their genitals, it's, yeah. But a lot of people cover the toilet seat with toilet paper or covers or all kinds of things because of that reason. Yeah. Or your mom told you not to sit all the way down on the toilet seat. Yeah.
I have strong legs.
Now, I always say skin is a great barrier as long as it's not broken. And in some ways, the shaving of pubic hair, sometimes that puts breaks in the skin. So from a public health standpoint, that's not something that has been the same through generations of women. In fact, it's been quite the opposite in many generations of women. But I just tell people to be real mindful that if you are shaving the pubic area, whether you're a male or female, that's breaking the skin. And then if you go and have sex, if there's gonorrhea or chlamydia or any other bacteria there, you've got a break in your skin. So.
What other questions do you all have? I'd be curious, do you get different psychological, emotional reactions from individuals depending on the type of STI, or is it just varied?
real varied. And a lot of times we will actually call in some of our behavioral health counselors, you know, somebody's very, very upset about the diagnosis of an STD. It's varied. And I try to emphasize the fact that everything is treatable. You know, that's, if there's good in the STD world, it's that we can diagnose and treat all STDs. So yeah, but there are some people who, you know, okay, I've got chlamydia, give me my 4 pills, on I go. And then there's some who feel very bad about having an STD. I don't think anyone should feel bad about having an STD, because a lot of times you got it from somebody who they didn't even know they had it. So the message I try to send is, let's take care of you now and make sure that it's treated.
Can you speak to the pubic area shaving? Because I've heard that that's more of a generational trend right now. Is that accurate, that young people are doing that more so than, say, older generations?
Right. And, you know, back in the 60s, it was kind of like, we're not going to shave anything. We're not going to shave our legs. We're not going to shave our underarms. We're not going to shave our pubic area. You know, if men don't have to do it, why should we? That was kind of the women's lib thing back in the 60s. And now people, more young women and young men, are shaving the pubic area. So yes, I think it's definitely generational. Some of the pictures and the slides I showed you, obviously women were not shaving all their pubic hair. And those were, I mean, some of those slides are 20 years old, but also some of those women were older. I don't think there's anything wrong with any way that people do it. I just tell people, you know, you got to make sure that you're not cutting yourself, you're using clean razors, and just realizing that does break the skin. So, yeah. Well, y'all have been real troopers to hang in there for STDs for like more than an hour.
Any other questions before we close out class today, y'all?
The HPV vaccine, are they going to try to get it into the childhood vaccines like the hepatitis B?
You know, that is a fabulous question. Would I love it if we did? Absolutely. Because it would protect so many people against cervical, penile, anal cancers without that messaging of, you know, this is protecting against a virus that you get from having sex. I think the resistance is, we've got so many childhood vaccines. You don't remember when you were 4, but we were popping you 5 and 6 times with all those vaccinations. So that's one of the resistance. I think a better thing that if we could, and the second thing is not required. So the other vaccines you had to have to go to public school. You don't have to have this one to do anything. And so therefore a lot of insurance companies wouldn't pay for it. And so out of pocket, it's like $180 a shot. And that's a lot of money. So if we could get it required, say, you know, require it for you to come to college. It's not now. That would be one thing. But then to make insurance companies have to pay for it. I think it's a shame, and this is my political bent, so take it for what it is, that we don't require and pay for all vaccinations and all vaccines. Kind of like we're doing the COVID vaccine. No one's having to pay for that. So we could do that. But great forward-thinking question. And hopefully, yes, maybe someday we will put it in the childhood vaccinations.
Because I'm pretty sure that we were like the first generation supposed to get it at 9 and 10. Yeah, because I remember my mom being very skeptical about the new vaccine.
Yep. And
it was brand new.
Because it was brand new. And hopefully we'll get more information for you so that when your generation has children, then we will vaccinate. And for when it first came out, we only did women. We didn't do women and men. Now it's women and men, duh. But so that we would vaccinate a whole generation. But you got to realize HPV causes cervical cancer. The reason you have to have a pap smear is because I have to make sure you don't have cervical cancer. If we eliminated cervical cancer, guess what else we could eliminate? Pap smears. How great would that be? So Not there yet, but maybe someday.
Any other questions before we close out class today? Okay, let's thank Dr. Beasley, and she will be back with us on Thursday.
We'll talk about birth control all day Thursday.
Yay. Thank you so
Thank
much.
you.
All right,
you.
thanks.
Thank you.
Bye. There's a thank you in the
you.
chat. Yeah. Have a good rest of your day.
Thanks. Bye. See you Thursday.
Bye.